Almost 2% of United States population live with disability related to traumatic brain injury. Motor vehicle accident. Hello dear students. Today our lecture will be about clinical features and pathophysiology of traumatic brain injury. So let's get to it. Learning objectives: to define and understand the mechanisms of injury for TBI, including primary and secondary injuries, mild and moderate TBI under the Glasgow Coma Scale, the metabolic dysfunction that occurs after TBI, and signs and symptoms of traumatic brain injury. Next one. Definition. Traumatic brain injury, TBI, is a non-degenerative, non-congenital insult to the brain from an external mechanical force, leading to permanent or temporary impairment of cognitive, physical, and psychosocial functions, with an associated diminished or altered state of consciousness. Epidemiology. Over 3 million head injuries each year. 500,000 of these require hospitalization. 70,000–90,000 will result in long-term disability. 50,000 deaths per year from traumatic brain injury. Almost 2% of United States population live with disability related to traumatic brain injury. Motor vehicle accidents, almost 50%. Falls, 20–30%, and interpersonal violence and sports. Incidence is highest in age from 15 to 24 years old. 2 peaks: early childhood due to child abuse, falls; elderly due to falls, 2:1 male-female ratio. Alcohol is involved in almost 50% of cases of traumatic brain injury. You can see, or you can remember, the anatomy. Here also you can remember some functions, cranial nerves. Next one. Metabolic dysfunction of TBI. The metabolic dysfunction that occurs with traumatic brain injury is initiated by the excessive release of excitatory amino acids, glutamase. These induce ionic shifts which ultimately lead to elevated intracellular calcium. The large influx of calcium ions stimulates the activation of proteases, kinases, phospholipases, and nitric oxide synthase. This can ultimately lead to free radical formation, a very significant part of secondary injury. Free radicals damage endothelial cells and injure the brain parenchyma. Free iron is a key catalyst of free radical mediated injury and is readily available in injured and contused brain tissue. Once initiated, free radical injury is a self-repeated process. Classification of traumatic brain injury. First, according to occurrence: primary, secondary, according to location, diffuse and focal, according to severity, open and closed. Primary TBI, concussion, contusion, hematoma, laceration. Secondary TBI, changed cerebral blood flow, hypoxia, infection, ischemia, raised ICP, intracerebral hemorrhage. Diffuse TBI, concussion, diffuse axonal injury, cerebral edema. And focal TBI, contusion, hematoma. Types of TBI. Primary brain injury refers to a direct result of damage suffered at the moment of impact. Secondary brain injury refers to damage sustained minutes, hours, or days after primary injury. Primary brain injury symptoms: skull fracture, contusions, concussions, lacerations, diffuse axonal injury, penetrating, non-penetrating. Acceleration injuries caused by movement of the brain within the unrestrained head. Non-acceleration injuries caused by injury to restrained head. Here you can see images. obvious external wound, open injury and closed injury. No obvious external signs. Closed head injury. Secondary brain injury: ischemia, hypoxia, hypertension, cerebral edema, raised intracranial pressure, hypercapnia, meningitis. Levels of TBI: mild, loss of consciousness and/or confusion and disorientation in shorter than 30 minutes. Glasgow Coma Scale 13 to 15. Moderate, loss of consciousness from 20 minutes to 6 hours. Glasgow Coma Scale 9 to 12. Severe, loss of consciousness of greater than 6 hours. Glasgow Coma Scale 3 to 8. Mild TBI. Other names for mild TBI: concussion, minor head trauma, minor TBI, minor brain injury, minor head injury. Symptoms such as fatigue, headaches, visual disturbances, memory loss, poor attention, concentration, sleep disturbances, dizziness or loss of balance, irritability, emotional disturbances, feelings of depression, seizures. Severe TBI: cognitive deficits, speech and language, sensory, perceptual, vision, hearing, smell, taste, seizures, physical changes, social, emotional. Primary injury. Here also you can remember a little bit anatomy. Skull fracture. In one study of TBI patients, 3% ED attendees, 65% neurosurgical intensive care unit admissions, 80% of fatalities sustained skull fracture. Skull fracture is highly associated with intracranial hemorrhages. Here you can remember anatomy, bones, cranial, skull fracture, depressed skull fracture. This is how it looks like. Linear fracture, which presents, or it can be in epidural hematoma or subdural hematoma. Depressed fracture, focal parenchymal lesion, skull base fracture and open head injuries. Knife, firearm, laceration of dura. Warning signs after a head injury: the first 24 hours, changes in LOC, increased drowsiness, confusion, difficult to arouse, seizures, bleeding or water drainage from nose or ears, pupils slow to react or unequal. Here you can see pupils unequal. Visual problems, loss of sensation to any extremity, slurred speech, projectile vomiting. Skull fracture, associated with a variety of trauma-related complications. Cerebrospinal fluid rhinorrhea results from a fracture in the cerebriform plate. Otorrhea results with fracture within the mastoid area cells or temporal bone. These carried from 2 to 9% risk of meningitis. Depressed skull fracture carry 31% long-term risk of late post-traumatic seizure. Temporal bone fracture can be associated with cranial nerve 7 damage or hearing loss. Skull base fractures. Most are extensions of fracture of cranial walls. Clinical clues: cerebrospinal fluid otorrhea or rhinorrhea, hemotympanum or laceration of EAC, post-auricular ecchymosis, preorbital ecchymosis in absence of direct orbital trauma is PE bilateral, cranial nerve injury, 1st, 6th, 7th, 8th, diastatic, fracture along suture lines, traumatic suture separation. Here you can see separation of sutures. Usually affects newborns and infants, and fused sutures, commonly unilateral, which means from two sides, from both of the sides. Most common location equals lambdoid and sagittal sutures. More than 2 mm separation, that is asymmetric. Depressed skull fracture. In adults, criteria to elevate: more than 8 to 10 millimeter depression or more than 1 thickness of skull. Here you can see depression of the skull. Deficit related to underlying brain. Cerebrospinal fluid or CSF leak. In children, 2 types. Simple depressed, usually remodeling occurs with growth, surgery if dura penetrated or persistent cosmetic defect. Ping pong ball fractures. Rentgenography if underlying brain injury or dura penetrated. Or surgery if underlying brain injury or dura penetrated. Because in children, in such fractures like ping pong ball fractures, they don't need any surgery. You can fix it with only one instrument with elevator under the skin. Skull-base fracture. Basilar skull fractures. You can see it here, fractures. Longitudinal basal skull fracture. Here transverse basal skull fracture. And here anterior basal skull fracture. Here the plane, sagittal plane. Here axial plane, superior view. Skull-base fracture symptoms associated with greater forces than simple cranial vault fractures. Classic signs: raccoon eyes. Here you can see raccoon eyes. All periorbital ecchymosis, representing cerebriform plate fractures. And basal sign. Here you can see basal sign. Postericral ecchymosis, representing ecchymosis over the mastoid process, associated with an ipsilateral skull fracture. Ipsilateral means on the side of fracture, on the fracture side. Sometimes cerebrospinal fluid otorrhea and also hematomia. Post-traumatic subarachnoid hemorrhage. Most common type of traumatic brain injury. Neurological emergency, blood collection beneath arachnoids due to terminal bridging vessels in the arachnoid space site next to brain contusion under subdural hematoma, fracture, scalp laceration can be distant because blood diffuse in the subarachnoid space. You can see it's shown with arrows here. Its color or its shade is little different than other whole brain. Subarachnoid hemorrhage. Circular villus with the most common locations of rupture aneurysms marks. Here you can see. Anterior communicating arteries aneurysm, 40% most common. Anterior communicating artery, if you remember from the anatomy, circular villus. Then middle cerebral artery, here you can see, and posterior communicating artery, 20%, middle cerebral artery, 34%, and here you can see basilar artery aneurysms, 4%. Hematomas. Here you can see the most common types of hematomas: epidural hematoma or extradural, also it's called epidural or extradural hematoma. Here dura, and here skull fracture, and here is blood material, but that's why it's called, because it's above the dura. That's why epi or extradural hematoma. And here is subdural hematoma, which means under dura. It's here, dura, blue colors, and here is venous blood. It's subdural hematoma. Here you can see, It is subdural hematoma, the crescentic shape, and its lenticular shape, epidural or extradural hematoma. Extradural hematoma, here's subdural hematoma. And here you can see cadaver, the cadavers, or in actual life how it looks like. Here you can see subdural. Next one. Subdural hematoma. Subdural hematomas are due to tearing of superficial bridging veins crossing the subdural space or hemorrhage from severe cerebral contusion, spread more diffusely over the hemisphere than extradural and often associated with diffuse swelling of the underlying hemisphere. Blood collects between dura and arachnoids. 10 to 20% of all cranial trauma cases, elderly, 60 to 80 years old, large shaken baby syndrome. On CT or MRI, subdural hematoma appears as a crescent shape. Clinical manifestation depends on type. Subdural hematoma, types or classification. First one, acute subdural hematoma, 1 to 3 days after onset. Coma in 56%, lucid interval 12 to 38%. Posterior fossa subdural hematoma, sign of increased intracranial pressure or ICP, result from torn bridging veins, cortical laceration, torn dural sinuses. Here you can see it. Subacute subdural hematoma, within 3 months, may be recognized when deviation of lateral ventricle midline shift, and also chronic, after 3 months, due to injury of small bridging veins, headache, apathy, cognitive impairment, proximal painness, and intermittent paraparesis. Crescentic hyperdense collection can cross suture. Shaken baby syndrome. It occurs on infants, so do not shake your children or do not shake kids. It can be dangerous. It can be dangerous to the health of the kids. Symptoms: retinal hemorrhaging, pale blue skin, and lethargic eyes. Management: surgery, burr hole, craniotomy, and non-operative, clinically stable, cloth thickness less than 10 mm, no clinical OCT signs of herniation. Repeat CT scans from 6 to 8 hours after initial scan. Here you can see skin incision, opening the skin, and here you can see 2 burr holes with craniotoma, and after that craniotomy, and that's it. Elevating of the blood, which is under or above the dura, and the stitches on the skin. Epidural hematoma, usually middle fossa via laceration of the middle meningeal artery, 90%, lenticular shaped, bounded by suture lines where the pericranial layer of dura attached to the skull, uncommon but serious 1 to 4% of TBI, highest among adolescents and young adults, associated with skull fractures in 75–95%. Here you can see it. Epidural or extradural hematoma. Classic presentation: brief post-traumatic LOC, lucid interval for several hours, followed by obturation, contralateral hemiparesis, ipsilateral pupillary dilation. No initial LOC in 60%, no lucid interval in 20%, CT scan, lens-shaped collections, management craniotomy more than 2 cm, active bleeding, impending herniation, indications for surgery, prognosed mortality 10%. Here you can see it, here you can see CT scan, CT imaging, and here. Several sign, here you can see. Small rounded lesion is advanced to the brain, representing active extravasation of unclotted blood. Contusions. When a head at rest is hit with a rapidly moving object, cortical bruising can appear at the site of impact, cope injury. When a head is in motion and hits a solid object, injury can be present not only at the site of impact but also at the opposite site, countercope injury, cope and countercope. Primary impact, secondary impact. Most common, frontal and temporal poles adjacent to bony surfaces of the skull base. Clinically, contusions can range from asymptomatic lesions to massive pulped areas of brain, with resulting herniation. Symptoms: headache, confusion, sleepiness, dizziness, loss of consciousness, nausea, and vomiting, seizures, and difficulty with coordination and movements. Centricope contusions, contusions that develop opposite the impact. The patient fell back and hit the occipital area. Here you can see these black parts. These black areas are contusions, post-mortem. Diffuse axonal injury, most severe of all primary brain lesions. Rotational forces cause a shift of brain tissue, most typically in the gray or and white matter border. Gray matter more dense than white may result in diffuse axonal injury, DAI. Range of presentations of patients with DAI can be mild traumatic brain injury to severe traumatic brain injury. LOC immediately at the time of trauma lead to coma. Frequent cause of persistent vegetative state. Clinical symptoms worse than CT findings. Can be isolated with no or little association with subarachnoid hematoma fracture. 3 grades for diffuse axonal injury, widely used: grade 1, grade 2, grade 3. Diffuse axonal injury is the most commonly cited cause in the absence of hemorrhages or intracranial pressure elevations, of prolonged depressed consciousness, and of severe disability in brain-injured individuals. Non-hemorrhagic 80% cases. Common locations: gray-white matter interface, corpus callosum, dorsolateral midbrain. Worse prognosis in multiple lesions. MRI most sensitive. Here you can see dia lesions of the brainstem. These black parts. Dia lesions of corpus callosum. Here you can see injuries. Vascular rupture but decay lesion is axonal damage. Axonal swelling is revealed by the beta epithelial stain in DAI. Severe white matter degeneration and atrophy of the corpus callosum in old diffuse axonal injury. Brownish color of the degenerated white matter due to old hemorrhages. Yes, you can see it. MRI demonstrates foci of high flare signal and the typical distribution of diffuse axonal injury. Here you can see it. Diffuse axonal injury. This young man was involved in a high-speed MVA with a closed head injury and has been slow to rehab. Here you can see a little bit here. Here you can see. multiple sites of edema and hemorrhage involving the brainstem and corpus callosum, as well as subcortical white matter and left cerebral peduncle. Here you can see it. Stem, brainstem, here. Here you can see it, here you can see it, sites. Brain damage. Secondary injury. Mechanisms. Macroscopic level: edema, ischemia, necrosis, elevated intracranial pressure, inadequate cerebral perfusion. Cellular level: energy failure associated with a cascade of events contributing to secondary injury and cell death. Elevated intracellular calcium, release of excitatory amino acids, generation of free radicals, breakdown of the cellular cytoskeleton and membrane with vascular dysfunction. Excitatory amino acids. First event in cascade: release of excitatory amino acids. Glutamate acts postsynaptically. NMDA receptor complex, ion channel, allows passage of calcium and sodium ions. When activated by glutamate, allows calcium ions to enter the cell. The N-methyl diaspartate receptor is a glutamate receptor and ion channel protein found in nerve cells. It is activated when glutamate and glycine bind to it, and when activated it allows positively charged ions to flow through the cell membrane. Here you can see it. Free radicals. Free radical formation is an important part of secondary injury. They damage endothelial cells and injure parenchyma. Free iron is a key catalyst of free radical mediated injury and is readily available in injury and contact brain tissue. Disruption of the blood-brain barrier, partly responsible for both pathogenic and cytotoxic edema. Once initiated, free radical injury is a self-repeated process. Inflammation. Inflammatory cytokines such as interleukins 1 beta, tumor necrosis factors alpha are greatly increased after injury, can increase in vasogenic edema. Studies have shown intracellular swelling is more prominent than extracellular swelling. Brain edema. Increased water content of brain and or increased intravascular blood volume. Severe condition. Can be fatal. Can be unilateral or bilateral. Evolves over 24-48 hours. Generally resolve in 2 weeks. You can see normal brain, edema of the brain. Vasogenic edema results from disruption of the blood-brain barrier. Injury to the endothelial cells lining the vessels of the brain allow for extravasation of fluids and protein into the interstitial space of the brain parenchyma. Cytotoxic edema refers to edema of the cells themselves. This results from failure of ATP-dependent cellular ion homeostasis and membrane dysfunction. Raised ICP or intracranial pressure. The three normal contents of the cranial vault are brain tissue 8%, blood 10%, and cerebrospinal fluid 10%. Normal state, ICP normal, 4 to 15 mm hydrargyrum normal, more than 20 mm hydrargyrum abnormal. The Monroe-Kelly doctrine states that the cranial vault is a rigid structure, and therefore the total volume of the contents determines intracranial pressure. Cerebral perfusion pressure, CPP, can be determined by the following formula. In trauma, recommended CPP not go below 70 mm hydrargyrum. In kids, not go below 60. Symptoms and signs of raised ICP: diminishing level of consciousness, headache, vomiting, seizures, Cushing's triad, bradycardia, hypertension, abnormal respiration, pupillary changes, papilledema, brain herniation, subfalcine herniation, ankle herniation, and central transtentorial herniation, tonsillar herniation, here you can see it, and reduced cerebral perfusion. Here you can see subfalcine herniation, ankle herniation, and central transtentorial herniation. Management of raised intracranial pressure includes airway protection and adequate ventilation. Intubation may be required. A bolus of mannitol 0.25 to 1 gram to kilogram causes. Free water diuresis, increased serum osmolality, and extraction of water from the brain require rapid neurosurgical evaluation. Ventriculostomy or craniotomy may be needed for definitive decompression. Brain oxygen monitor. Here you can see ICP monitor, ventricular catheter, brain oxygen monitor, both. And here you can see contusions. Medication. Anti-anxiety medication to lessen feelings of nervousness and fear. Anticoagulants to prevent blood clots. Anticonvulsants to prevent seizures. Antidepressants to treat symptoms of depression and mood instability. Diuretics to help remove fluid that can increase pressure inside the brain. Muscle relaxants to reduce muscle spasms. Stimulants to increase alertness and attention. Concussion, CDC definition. A complex pathophysiologic process affecting the brain induced by traumatic biomechanical forces caused by a jolt to the head or body that disrupts the function of the brain, typically associated with normal structural neuroimaging findings, such as CT scan, MRI, results in a constellation of physical, cognitive, emotional, or sleep-related symptoms that may or may not involve a loss of consciousness, (LOC). Duration of symptoms is highly variable and may last from several minutes to days, weeks, months, or longer in some cases. Most commonly reported symptoms: athletes with concussion, from 1 to 7 days following concussion. Symptoms may evolve over time. You can see most common symptoms: headache, difficulty concentrating, fatigue, drowsiness, dizziness, foggy, feeling slowed down, light sensitivity, balance problems, and difficulty with memory. Second impact syndrome. Catastrophic brain swelling occurring if a second concussion happens before complete recovery from a first one. Only found in adolescents. Intracranial vasodilation and cerebrovascular congestion. Vascular after-regulation dysfunction. Here you can see images how it happens. Second impact syndrome. Often the second blow appears quite minor. Player might appear dazed, but often can leave the field under his own power. Swelling can start within 15 seconds to a couple of minutes. Brainstem failure within 2 to 5 minutes. Fatal in most cases. You can remember the great example of Muhammad Ali. Second most, or another boxers, most common example of second impact syndrome. Intracerebral hemorrhage, a blood clot deep in the middle of the brain that is hard to remove. Pressure from this clot may cause damage to the brain. Surgery may be needed to relieve the pressure. Here you can see it. Intracerebral hemorrhage. And here you can see in the imaging symptoms, other factors. Brain death. Severe increased intracranial pressure, decreased cerebral blood flow, then irreversible loss of brain function. Clinical criteria: coma plus absent brain stem reflexes, no flow in intracranial arteries or venous sinuses, diffuse cerebral edema, pseudosubarachnoids with visualization of contrast, enhancement of intracranial vessels. Only external carotid artery branches are enhanced. You can see it here. Like the structural brain tissue, all like the one thing. Like there is no differentiating. You can't differentiate. It's like the whole one thing or one tissue. You can see here only this external carotid arterial branches here and here, and that's it. Nothing more. Conclusion. Computer tomography or CT, primary modality for head trauma, enough for most parts. Skull X-ray still used in penetrating trauma, suspected child abuse. MRI to help predicting prognosis by detection of subtle injuries, such as contusion and diffuse axonal injury, primary versus secondary lesion, often secondary lesion more important. So, thank you for your attention. Hello dear students. Today's our lecture will be about clinical features and pathophysiology of traumatic brain injury. So, let's get to it. Learning objectives: to define and understand the mechanisms of injury for TBI, including primary and secondary injuries, mild and moderate TBI under the Glasgow Coma Scale, the metabolic dysfunction that occurs after TBI, and signs and symptoms of traumatic brain injury. Next one. Definition. Traumatic brain injury, TBI, is a non-degenerative, non-congenital insult to the brain from an external mechanical force, leading to permanent or temporary impairment of cognitive, physical, and psychosocial functions, with an associated diminished or altered state of consciousness. Epidemiology. Over 3 million head injuries each year. 500,000 of these require hospitalization. 70,000, 90,000 will result in long-term disability. 50,000 deaths per year from traumatic brain injury. Almost 2% of United States population live with disability related to traumatic brain injury. Motor vehicle accidents, almost 50%. Falls, 20 to 30%, and interpersonal violence and sports. Incidence is highest in age from 15 to 24 years old. 2 peaks: early childhood due to child abuse, falls; elderly due to falls, 2 to 1 male-female ratio. Alcoholism involves in almost 50% of cases of traumatic brain injury. Here you can see, or you can remember, the anatomy. Here also you can remember some functions, cranial nerves. Next one. Metabolic dysfunction of TBI. The metabolic dysfunction that occurs with traumatic brain injury is initiated by the excessive release of excitatory amino acids, glutamate. These induce ionic shifts, which ultimately lead to elevated intracellular calcium. The large influx of calcium ions stimulates the activation of proteases, kinases, phosphorylase phospholipase, and nitric oxide synthase. This can ultimately lead to free radical formation of very significant parts of secondary injury. Free radicals damage endothelial cells and injure the brain parenchyma. Free iron is a key catalyst of free radical mediated injury and is readily available in injured and contused brain tissue. Once initiated, free radical injury is a self-repeated process. Classification of traumatic brain injury. First, according to occurrence: primary, secondary, according to location, diffuse and focal, according to severity, open and closed. Primary: TBI, concussion, contusion, hematoma, laceration. Secondary TBI: changed cerebral blood flow, hypoxia, infection, ischemia, raised ICP, intracerebral hemorrhage. Diffuse TBI: concussion, diffuse axonal injury, cerebral edema. And focal TBI: contusion, hematoma. Types of TBI. Primary brain injury refers to a direct result of damage suffered at the moment of impact. Secondary brain injury refers to damage sustained minutes, hours, or days after primary injury. Primary brain injury. Symptoms: skull fracture, contusions, concussions, lacerations, diffuse axonal injury, penetrating, non-penetrating. Acceleration injuries caused by movement of the brain within the unrestrained head. Non-acceleration injuries caused by injury to restrained head. Here you can see images. Obvious external wounds, open injury and closed injury. No obvious external signs. Closed head injury. Secondary brain injury: ischemia, hypoxia, hypertension, cerebral edema, raised intracranial pressure, hypercapnia, meningitis. Levels of TBI: mild, loss of consciousness and/or confusion and disorientation in shorter than 30 minutes. Glasgow Coma Scale 13 to 15. Moderate, loss of consciousness from 20 minutes to 6 hours. Glasgow Coma Scale 9 to 12. Severe